Hello, everyone. Thanks for joining. So today's session is going to focus on infective uveitis. It's quite a big topic, and the session is going to be pretty sort of information heavy. So feel free to sort of pause as and when you want and break this up as much as you want. But uveitis already is a very broad topic. There's lots of different things that contribute to intraocular inflammation, and infections is a really important cause of inflammation in the eye. And it's one that you really mustn't forget. So, um, in today's session, we're going to look at different types of infective uveitis. So, looking at bacterial, viral, fungal, and parasitic causes, the different types of causes, looking at specific microorganisms, how they present in the eye. And there's a lot of overlap in how they present, but the management can be really quite directed at the probable microorganism. So generally with infective uveitis, it might be a rare cause of inflammation. It's a bit more common when you're looking at something like posterior uveitis, but for anterior uveitis, infective causes may not be the most common things that are causing an anterior inflammation. Um, but it's a very important cause, especially when you're looking at posterior uveitis. And your clinical assessment can really help narrow down your differentials in terms of what's the history, how long has everything been going on, is there a travel history, does the patient have any pets? Um, and also what the actual clinical examination looks like. And don't forget to consider infective causes. It can really dramatically change your management. You know, patients that you may typically absolutely douse in steroids, you may not want to if you're worried about an infective cause. So do consider if an infective cause is something that's slightly higher up your differential list, either based on the patient's medical history, the patient's social history, or how the actual patient has presented to you in your clinic. So with bacterial uveitis, these are sort of your main things, tuberculosis and syphilis, and also your main sort of endophthalmitis is usually bacterial as well. So with tuberculosis, your ocular inflammation can actually quite often occur without any systemic symptoms. So these patients can sometimes be presenting being completely otherwise well. And you'll have an anterior uveitis, you'll probably have a bit of a vitritis, and there's lots of different things that can happen in the eye. It's a bit like what TB is like elsewhere in the body. It can cause almost anything. Um, so do consider it when you're seeing things like granulomas, any sort of choroiditis, and sometimes also the anterior sort of ocular surface layers can be involved as well with scleritis and conjunctivitis as well. And TB uveitis, like I said, lots of different presentations, and it can be difficult to know solely from the clinical exam. So you want to be considering things like the patient history. Have they traveled? Are they actually on any active treatment for TB? Do they have any systemic manifestations of the disease? But like we said, quite often what you might find is that these patients don't have any systemic symptoms and they have an isolated TB in the eye. And these pictures sort of show you what TB can look like. And TB can sometimes cause, so for example, in this lower right-hand picture, it can cause a an occlusive episode, and you can end up with something like a BRVO, or it can cause like granulomas, like you can see here in the top right. So there's lots of different things that TB uveitis can actually cause. When it comes to investigating it, obviously it's a clinical diagnosis usually, but you may want to look at things like looking for systemic TB, either with a quantiferon or an IGRA potentially. You're going to want to do a chest X-ray. You're going to want to look at any bloodborne viruses. Is the patient immunocompromised? Usually you don't have to sample the actual eye, so you don't really need to do a vitreous sample or a aqueous sample. But an OCT is going to be helpful at assessing your macular and also an FFA and an ICG if you're looking at for any sort of chorioretinitis as well. So you're going to treat the TB. It's a long treatment. You've got the multi-drug therapy. Consider the side effects of something like an ethambutol with optic neuropathy. These patients can benefit from topical steroids or even sometimes systemic steroids to help with the inflammation. And later on down the line, if these are patients that then develop CNV or neovascularization, some laser may also help to treat the sort of complications of having ocular TB. Syphilis. So, syphilis comes in both like primary, secondary, and tertiary syphilis. There's also like a latent syphilis as well, but that's less relevant here. And your sort of ocular syphilis tends to fall into that secondary or tertiary infections. And again, it varies as to how it presents in the eye. So you can get an anterior uveitis or chorioretinitis. There's a specific syndrome with acute syphilitic posterior placoid chorioretinopathy. That's something that you can see at the back of the eye, particularly at the retina, at the macula, sorry, a retinitis, and it can also affect your optic nerve as well with a neuroretinitis as well. So If you're getting a unilateral disc swelling, posterior inflammation, do consider syphilis as a potential cause. Remember to take a sexual history from this patient. In this bottom left-hand picture, you can see a typical case of a macular star in the context of a neuroretinitis. So do consider syphilis as a potential cause in these patients. You're going to send it for VDRL, but remember that these can sometimes be incorrectly positive in an HIV positive patient, which is why we'll also do some bloodborne virus testing. You can also take some aqueous sampling as well and send it off for serology too. They're going to be treated with penicillin. Interestingly, by treating the syphilis, you can sometimes cause a progression of your ocular signs, and that's a reaction that can sometimes be seen, and that's why sometimes you want to give them concurrent topical steroids as well to help manage the ocular inflammation, which can sometimes worsen by treating the underlying syphilis. Endogenous endophthalmitis. So specifically with bacterial causes of endogenous endophthalmitis, you're looking at things like risk factors such as IVDUs, any sort of long-term catheters, tooth abscesses, endocarditis. All of these things can shoot off infective emboli to the eye and cause an endophthalmitis. It'll be a very similar picture to an exogenous endophthalmitis. You'll treat it very similarly with a tap and inject, but these are patients who are going to get a systemic investigation to try and find a focus of an infection. So that should say, sorry, of a focus of infection. So these are patients, you'll get an echo. They may have like a urine dip, for example. You're looking for an infective focus point. And they're going to get the ocular treatment, but also the systemic treatment here is really key because these are patients who they may have the local treatment to the eye, but they need systemic treatment because this is coming from somewhere else in the body. And just some honorable mentions of other causes of bacterial uveitis. So these are just think of the bees. So you've got Borrelia, sorry, Bartonella and Brucella, and these are all different kind of microorganisms, specifically bacteria, that can give you this posterior uveitis. So with Lyme disease, you can get an episcleritis and neuroretinitis. Again, you'll be treating that with penicillin. Cat scratch disease, which is your Bartonella, typically coming from patients who have cats, for example, but they can sometimes come from completely with no pets or no history of a scratch. Again, in neuroretinitis. A lot of the time with cat scratch disease, these are actually self-limiting. So a lot of the patients can simply just get some monitoring and watch the disease settle down, or you can maybe give them a 4 to 6 week course of doxycycline or potentially erythromycin if you're dealing with children. And then with brucella, this is typically from your milk products or uncooked meat. Again, your sort of chronic uveitis, perhaps some retinal hemorrhages, and these are patients that are going to be treated with either a streptomycin or a doxycycline with potentially some steroids as well to help manage the inflammation. Moving on to viral uveitis. Viral uveitis can really go undiagnosed for long periods of times. These are patients that can come sometimes with chronic inflammation, sometimes hypertensive, and these viral uveitis can be much, much worse in the context of immunodeficiency, such as HIV. HIV itself can cause a microangiopathy, and your low CD4 counts are where it gets really worrying because you get these opportunistic infections that we're going to talk about in a moment. And think of things like systemic manifestations like Kaposi's, for example. And like I said, these low CD4 counts open the door to opportunistic eye infections, particularly with CMV. So CMV is usually completely asymptomatic in the healthy individual. Lots of people may be carrying CMV, but it doesn't necessarily rear its head in any sort of form. But immunosuppressions and low CD4 counts can really cause quite devastating ocular disease. So you've got CMV retinitis and you've got necrosis, a uveitis as well. And these are patients that are going to need a CD4 count and potentially also some aqueous sampling and a PCR. And treating CMV really, the underlying immunosuppression is really important because by dealing with the immunosuppression, you can then help settle down the CMV disease. So these are patients who are going to need some antiretroviral treatment, especially if they're, HIV positive, for example, and that's what they're getting it for. And you keep going and you keep treating the CMV with ganciclovir, for example, until your CD4 counts come back up to about 100 to 150. And in terms of treating the CMV, oral ganciclovir has quite good effects, intravitreal ganciclovir as well, and steroids to help settle that inflammation down. And these are all pictures of what you can see with a CMV retinitis. These, swathes of ischemia along the retinal vessels with hemorrhaging as well. And prognostically, these patients sometimes do really quite poorly because of that necrosis that you're getting at the retina. CMV uveitis, specifically with an anterior uveitis, is much more common than we might think. It's typically hypertensive, and that's why sometimes you might work somewhere where when you're seeing a hypertensive uveitis, your SOP may actually include taking an aqueous sample and sending off for a PCR because oral ganciclovir can help treat these patients. And these are sometimes, unfortunately, patients who come in with very high pressures. And actually, even when treating the CMV, the high pressures may persist and they may go on to develop a secondary glaucoma. A quick comment on varicella. So varicella uveitis, it's present in about 50% of those with HZO. So make sure you're looking for this. If somebody comes in with a shingles and some cornea uptake with some fluorescein, make sure you're looking for some inflammation. You might see some iris atrophy. They may also have a high IOP. But if you find a posterior uveitis, be very, very alert and make sure you have a good retinal exam because these are patients that may be suffering from really quite devastating retinal disease, which we'll talk about now. So, progressive retinal necrosis, usually sometimes also cause a progressive outer retinal necrosis. It's usually caused by VZV, and it's something that you typically see in the immunocompromised. So when you're trying to compare PRN to ARN, which I'll talk about in the next slide, PRN typically is a disease of the immunocompromised. It's a necrotizing retinitis, and it tends to be very rapidly progressive. It's a unilateral vision loss, and also something that compares it to ARN is that you don't have a lot of anterior segment findings. So PRN is typically immunocompromised, and you also typically don't actually have a moderate or severe anterior inflammatory response. It tends to be actually very mild. You have a sort of three-stage retinitis. It starts off with these sort of yellowish infiltrates. They then sort of spread around the retina, and then you can then develop a rhegmatogenous retinal detachment, optic atrophy. You're going to think about doing vitreous sampling in a patient like this, and these are patients who are going to get some intravitreal ganciclovir or foscarnet, and they may actually get that several times. And if I'm honest with you, in terms of prognosis, patients with progressive retinal necrosis and also actually acute retinal necrosis, unfortunately, tend to do quite poorly. Um, and so with ARN, in terms of comparing the two, they look very similar at the back of the eye. You're getting these areas of retinal necrosis, hemorrhaging, potentially a retinal detachment. The difference is ARN is typically a patient who's otherwise healthy. And you also actually get quite a prominent anterior uveitis, and that's part of the diagnostic criteria for ARN as well. So while it's usually VZV in the elderly, it tends to be more herpes simplex that's causing something like this in the young. And again, that main differentiating factor between ARN and PRN is that in ARN, it tends to be a healthy patient and you have quite a prominent anterior inflammatory response as well. It's a very painful vision loss. Your diagnostic criteria is this prominent anterior uveitis with one or more foci of peripheral retinal necrosis, which you can see here in the pale retina. It spreads circumferentially around the eye, and then you can also develop an occlusive retinal vasculitis, central retinal artery occlusions, etc. And that's why these patients have, unfortunately, quite a devastating ocular outcome. You'll treat them with IV acyclovir for 2 weeks. It's quite an intense treatment for these patients. And they'll also get some intravitreal treatment as well. Steroids can be quite helpful to help manage the inflammation. And then later down the line, if they're getting any neovascularization or complications of an ischemic eye, they may benefit from from retinal laser as well. So the main learning points in this specific thing is that one of the main things that people struggle with is understanding the difference between PRN and ARN. For exam purposes, it's the immuno sort of status of your patient, and whether or not you've got a lot of anterior inflammation. And from a treatment point of view, patients with ARN are going to have long-term acyclovir, and have quite intense antiviral treatment in the early period. Other causes of viral uveitis, so you've got things like rubella, measles, mumps. Rubella, so in the congenital rubella, you might have like a salt and pepper retinopathy. They may come with a congenital cataract or glaucoma, microphthalmos. This picture here shows a sort of salt and pepper retinopathy in a patient with rubella. With measles, you may have a posterior uveitis as well. Mumps tends to be a more sort of anterior or intermediate uveitis, something like an iridocyclitis, for example, or a keratitis. And with Ebola, after the Ebola infection, these patients can then also develop what we call a post-infection uveitis as well. So moving on to fungal uveitis, there's lots of different types of fungal infections. Lots of fungi can present in the eye, and many can then progress to endophthalmitis, and can be quite difficult to diagnose fungal uveitis sometimes because it can present quite insidiously. But the other thing with fungal uveitis is that it can also be quite difficult to know exactly what fungus you're looking at. So sometimes, while the treatment can be very similar, your sampling can sometimes be quite important here. So Candida endophthalmitis, it can either be exogenous or endogenous. So with exogenous endophthalmitis, you're looking at things like having trauma, for example, organic material entering the eye, or it can be endogenous from a systemic candidemia. So patients with who are IVDUs again, intravenous drug users, the immunocompromised, long-term catheters again, chronic lung disease like cystic fibrosis, or even diabetes can increase that risk of having a candidemia and a systemic candidemia, which can cause a candida endophthalmitis. And they may already be diagnosed with a systemic candidemia, either with a blood culture, for example, or they may present with, for example, a vitritis, a chorioretinitis, even retinal detachment. Um, and you may want to try and investigate these patients with a vitreous biopsy. You're going to start off with antifungal treatment. It will just depend on where you work in terms of what the local guidance is. Usually something like an amphotericin B or maybe some oral or intravitreal voriconazole. And sometimes a vitrectomy can be really helpful. So these pictures, just before I go into what a vitrectomy is, or what it is in the context of a candida endophthalmitis, you see these sort of focal points of candidemia, sometimes being much more dramatic. Um, your vitreous is almost like an agar. So it's a great medium for fungus to grow. And that's the same for things like a bacterial endophthalmitis as well, which is why a vitrectomy can sometimes be helpful, because it reduces that sort of fungal load in the eye by getting rid of quite a lot of where your fungus is. The other thing that it helps as well is by getting rid of that vitreous, getting rid of that load in the eye. It also might make your treatments actually be much more available to the retina and to the eye itself by getting rid of that vitreous. So vitrectomy can sometimes be very helpful. Just a quick mention of other fungal infections. You've got things like pneumocystis, cryptococcus, aspergillus, coccidio, idomycosis. So there's lots of different fungi that can cause very similar pictures in the eye. At the end of the day, you're giving antifungal treatment. You're considering doing things like a vitrectomy, and you're wondering whether or not this is if it's an endogenous cause. You're trying to find the focal point of the infection elsewhere in the body. And a final point on presumed ocular histoplasmosis syndrome. I won't go into the white dot syndromes today. I'll do another session looking at this specific, the different white dot syndromes. But POHS is sort of sometimes grouped with your white dot syndromes because you get these white dots in the back of the eye. It's from histoplasma. Usually it's an inhaled disease, and it's presumed because actually the causality has never been proven in terms of the histoplasmosis, but I think up to 90% of patients with this picture test positive with skin testing. So it tends to be asymptomatic until you essentially get CNV at the macula. And there's a typical triad, or you get these white atrophic spots, some peripapillary atrophy, as you can see in this picture, specifically in the lower right-hand corner. And very specifically with POHS, you also have no vitritis. So when it comes to your exams, when it comes to sort of trying to figure out whether or not this white dot syndrome is POHS, it's typically no vitritis. You get this peripapillary atrophy and these white atrophic changes. And while CNV is rare, that is what usually causes the vision loss in the case of POHS. You can investigate with HLA testing, things like B7, DRW2. These are things that are related to POHS. You could do some serology, and you'll usually investigate these patients with an OCT, looking for things like evidence of a CNV. Do they have any fluid at the macula as well? And an FFA as well to look for the chorioretinitis. And then their treatment is actually usually just directed towards the CMV. So you don't do anything necessarily to treat any histoplasmosis, but you treat the CMV, and that will be with things like anti-VEGFs as well. Just your sort of usual anti-VEGF treatments that you can give. They'll usually be off-label though, because this is a very specific use for anti-VEGFs. So lastly, talking about parasitic uveitis, these are actually probably your most important causes because toxoplasmosis is actually the most common identifiable cause of a focal retinitis. So it's a really, really important thing to understand, to be aware of, and to appreciate when you treat and how you treat. And actually, when you have a posterior uveitis, when you see a vitritis in somebody's eye, when you see a chorioretinitis, up to 60% of those cases can be caused by toxoplasmosis. So it's really important you know how this works. There's multiple modes of transmission. It's usually to do with cats. They're the sort of main host, but then they can then move on to hosts such as, livestock, for example, and then it's ingested by the human. And there's lots of systemic and ocular features. So So with systemic toxoplasmosis, you can end up with a sort of meningoencephalitis in severe cases, and the ocular features are quite involved as well. This is just a picture of an MRI showing someone with toxoplasmosis in the brain. In terms of ocular toxoplasmosis, this picture is very typical of your lesion, where you get this hyper and hypopigmented lesion of the retina. This patient's been very unlucky in that that lesion is pretty much bang on in the middle of the macula. But if they come in with symptomatic toxoplasmosis, it is quite often asymptomatic. But if they come in with symptomatic toxo, they usually have some floaters. They may have some vision loss, maybe because of a vitritis or depending on where that lesion is. And that retina will show you a focus of inflammation. You may see some old foci as well. But if it's just the first presentation, you'll see a focus of inflammation, possibly some neuroretinitis, and you'll get this sort of punctate retinal toxoplasmosis where you can see it. Now, the vitreous you can have quite a marked vitritis, which is where you get this typical headlight in the fog when you kind of read that in some of your questions, because you get this bright white focus of inflammation that you can see through a very dense vitritis, which is your fog. Your optic nerve could be swollen. You may have an anterior uveitis. Sometimes that's just basically spillover from the vitritis at the back of the eye. You'll investigate with some serology. You may want to consider taking a PCR of the eye. And then also you want to do some OCTs and some FFAs to monitor the eye, look at the macula, and see whether or not this patient needs treatment. When it comes to treating toxoplasmosis, you don't always treat it. If it's a peripheral region, it's sometimes visually insignificant and it's self-resolving, or in terms of it's self-limiting in terms of its course. But there are certain things that would make you want to actually actively treat toxoplasmosis. It's typically patients with macular lesions, any lesions along the papillomacular bundle, next to the optic nerve head, if it's near a major blood vessel. And these are all because these are patients who are more at risk of having their toxoplasmosis either affect their vision or spread to other parts of their body, or they're immunocompromised because, again, they can develop much more severe disease. So your treatment options are, you'll have heard something like a triple therapy. The triple therapy is typically steroids, pyrimethamine, and sulfadiazine. The steroids start high dose, you then lower it down, and you sometimes, that should say a delayed start, you sometimes wait a couple of days to let the pyrimethamine and sulfadiazine work before you start them on steroids. And then the pyrimethamine starts with a loading dose first, and then you maintain the dosage, you give it with folinic acid, and the sulfadiazine as well. There are some other agents that can be used because pyrimethamine and sulfadiazine can't be used in pregnancy, so things like azithromycin, cotrimoxazole. Sometimes you can just use cotrimoxazole with the steroids as well, but it's not as good. Clindamycin, atovaquone, there's lots of different treatments for toxoplasmosis. And you can also consider giving intravitreal therapy, usually with clindamycin and steroids. And where intravitreal therapy can be really helpful is in, for example, patients who are pregnant, who you want to avoid systemic treatment. You can sometimes replace that systemic treatment by giving some ocular treatment. And again, they may need sometimes multiple doses of these intravitreals. And in pregnancy, you'll avoid the pyrimethamine and the sulfadiazine. You'd consider something like an azithromycin or a clindamycin, potentially with some steroids or speromycin. A vitrectomy can sometimes be handy, again, by getting rid of that vitritis, and again, by reducing that load in the eye and getting your active sort of treatments more kind of efficacious at the retina, because you've gotten rid of that agar in the middle. So toxocariasis, similar to toxo in sometimes how it presents, but it can sometimes be a bit more dramatic in terms of the vision. Toxoplasmosis is a bit kinder to the eye unless you're looking at macular lesions, whereas toxocariasis can be a bit more dramatic to the vision. It can be asymptomatic depending on where the lesions are. Or you can have this sort of chronic endophthalmitis, these gray white exudates. You can actually even have a granulomatous growth in the posterior segment, and then you get this diffuse unilateral subacute neuroretinitis, which I'll talk about specifically later down the line. But these pictures show you what toxocariasis can look like. Toxocariasis tends to have like an eosinophilia on your FBC. You may see a high IgE if you're looking at your immunoglobulins. You'll do a serology, you'll do some aqueous sampling. A B scan can be helpful as well if you don't have a good view of the back of the eye. You'll treat with steroids, and that should say antihelminths with a dash, something like mebendazole, for example. But do remember that when you're treating toxocariasis and when you're treating these helminths, by killing off the worms, sometimes the death of the worm itself can cause a lot of inflammation inflammation. So you may want to consider giving some steroids alongside the treatment when you're actually treating the Helminth infection, and a vitrectomy again for the same reason as discussed previously in the session. So just some honorable mentions. So onchocerciasis, this is the second most common cause of infectious blindness after trachoma. It's your Simulian black fly for the purposes of your exams. You sometimes have the systemic symptoms, things like a rash, for example, areas of hypo and hyperpigmented skin. And actually ocularly, you may actually see on the slit lamp the live microfilary. So what you can sometimes do by basically just lying the patient forward, these filiary can come to the front and you can literally just see them floating around in your AC, in your cornea, at the back of the eye. And you can treat these patients with ivermectin. Ivermectin is actually given for free in these high epidemic areas once a year to help reduce the transmission rate. And actually, there's some areas that have shown absolutely no new cases with the ivermectin. So it's been really, really successful at treating this, and some steroids again to treat the infection. So cysticercosis, this is a pork tapeworm. It can either present in the brain, but you can also actually see the cysts on the slit lamp, either in the conjunctiva or again the AC. Those cysts can actually lie underneath the retina, causing an exudative retinal detachment. And again, you're either going to surgically remove these, either with a washout, for example, and some steroids to help reduce the infection. And we spoke about DUSN. So this is where you can see like a single motile nematode at the back of the eye. And this picture here on the right you can see this sort of worm right by the fovea. And this can sometimes be a very insidious process where it starts off with just a bit of focal atrophy, and that can progress to just diffuse degeneration of your RPE and loss of your vision. And you essentially treat this by literally just lasering it. So you can apply some laser. Sometimes you apply some laser to try and draw this worm away from your fovea and then laser it essentially dead. And that's how you would treat something like this. So, in summary, it's quite an information dense sort of tutorial. Feel free to sort of go back, pause things, but there's lots of different infective causes of uveitis. So always make sure that you're taking a good history from your patient, include a social history, understand whether or not they have pets, and definitely your alarm bells should be ringing, specifically when you're looking at posterior uveitis. So if you're seeing a posterior uveitis, make sure you're dilating that patient, look at that retina, check your peripheral retina, and based on those clues, you can narrow your diagnosis down. So even though with anterior uveitis, a purely isolated anterior uveitis, infectious causes are not your most common things. They are very common causes of posterior uveitis. So make sure you are looking for these things and asking the right questions when you're seeing a vitritis, when you're seeing a chorioretinitis. So thank you for joining. The feedback is really helpful. There's a link in the description if you're watching this online. Um, it helps me sort of understand how these sessions are going, and there's a link in that feedback to then kind of suggest to me topics that you want me to cover. So thanks for joining, and we'll see you at the next one as we progress through the uveitis specialty. We'll kind of touch on some white dot syndromes as well and some other inflammatory processes in the eye.